On-the-scene coverage of ACC 2015 is supported by Effiant.
I'm Peter Block in San Diego at ACC 2015. With me is Sanjit Jolly from Hamilton, Canada. And we have just talked about his trial, which is once again aspiration thrombectomy with PCI. So Sanjit, this has been done a number of times before, and all the trials seem to indicate, why are we doing this? And that you did it again. So tell me what you found.
So, I think this is an important question. Interventional cardiologists believe in their heart that sucking out thrombus is a good thing to do. And there was discrepant findings. TOPAS suggested that perhaps mortality can be reduced by half. The TASTE trial suggested, in fact, that it's quite neutral, so there's no benefit. So we've now done the largest trial to help answer this question. So we randomized nearly 11,000 patients in 20 countries to an upfront strategy of routine thrombectomy versus PCI alone with only bailout thrombectomy.
Okay, so let me interrupt and say, is this an acute coronary syndromes, or this is any come-as-you-go kind of PCI?
Yeah, this is particularly ST elevation MI, the subset of patients who have the greatest thrombus.
Okay, so patients who are likely to have thrombus burden, but not routine PCI.
That's right.
Fair enough. So what'd you find?
So we found no difference in our primary outcome of cardiovascular death, recurrent MI, and shock at 180 days. And we found no difference in mortality. What we did find is our key safety outcome of stroke within 30 days was increased, and statistically significantly so.
What are the absolute numbers of that, Sanjit? Because that's sort of a, whoa, just a minute, let's take another look at that. So what are the numbers?
Yeah, 0.7% versus 0.3%. And I think that's important because the overall rate of stroke was very low in the trial. And you would expect a stroke rate of somewhere between 1% and 2% when you look at other published literature. So actually both were fairly safe. And it was only a trial of this size and magnitude that you'd actually be able to detect small differences.
Okay, but in all fairness though, less than 1% is still a pretty good batting average for stroke.
Yeah, it's absolutely true. So, I think we need to be cautious. Clearly, any increase in stroke is not something we want as physicians, but these are small numbers, and generally patients did well.
Okay, so here I am, I'm still an interventional cardiologist, even though I'm interviewing you. So, and if I see a lot of thrombus, my first reaction is I've got to get that out. Tell me if you think that still is reasonable in some patients.
The trial did not test for selective thrombectomy, so we can't directly answer that. What we do know is that in our PCI alone group, there was bailout thrombectomy in about 7% of cases. So what we know from the arm is that it's fairly safe to balloon some of these patients, and in a small proportion you'll have to do a thrombectomy because the ballooning is simply not opening up the artery. And of the 300 to 400 patients who had bailout, there were no strokes in the patients who had bailout thrombectomy. This would suggest that actually seems like a reasonable strategy. So start off with a standard PCI strategy, and if you've got a lot of thrombus and it's not working, because there are some cases when you balloon and everything seems to disappear. There are other cases you balloon and the vessel occludes and you can't get it open.
Okay, so I guess it's fair to say that aspiration thrombectomy, for all intents and purposes, should not be done. Probably is a dead issue. But for some cases, it's still something that at least reach for the catheter and think about getting it out if you really need to. But it sounds to me like this is a pretty good indicator that thrombectomy after, during PCI and ST elevation probably shouldn't be done.
Yeah, as a routine strategy, no. In selected cases when things aren't working, it's still a rescue therapy.
Thank you, Sanjit.